that workshop was all about, has the WCB abandoned its mandate? And so we had an amazing day and a half session around that topic. And a lot of great things have been happening since then related to the activities we wanted to pursue from that workshop. Our last keynote speaker series, we had Beth Kilgore and Iggy Cosney. And they were speaking about the interaction between injured workers and the workers' compensation system. So, and as I mentioned, some of these talks are available online. Just check in with us and we can point you to where you can find them. A few housekeeping items I should mention. We're doing a test of podcasting this event. This is our first time trying it out, so have some patience with us. There's some off-site groups in Thunder Bay and elsewhere that are linking into this live, and they're able to also ask questions via the telecommunication system that we're using. But we need you to also then use the microphones when you ask questions or make comments. We have somebody who will be walking around with a roaming mic to help facilitate that, but it's important for them to hear what's happening here in the room as well. So you need to use the mic to make sure that the people on the linking in remotely can hear what you're talking about. Let's see. So they were also video recording this event. So you in the audience won't be video recorded, but there's a camera over here that's actually positioned up here. So keep that in mind if you don't want to be on the video, to not wander about back here, kind of thing. But we'll make sure that we meet everybody's preferences in either being in or out in terms of the video recording. Let me see what else we have to do. So the washrooms, very important. This is the first time we're using this venue too, so we'd like to hear your thoughts on what you think of this venue. In the past, we've been at Victoria College, which is just down the hall. In this facility, the bathrooms for accessible ones are on the main floor, just outside the hall, for men and women, combined one. There's a larger set of washrooms downstairs. If you go across the hall, down the stairs, and to the left. I always get left and right. So to the left, there's some facilities down there as well, washrooms for men and women. Great day and wonderful patio. So if you're so inclined, and want to need a break, you can step outside or go back to the back and get a coffee or a snack at your leisure. We don't actually have an official break, so if you do it quietly and at your leisure, feel free to get up and move around if you so need to or choose to. Tea and coffee and snacks are available at the back. So we're asking people who are salaried to donate $10 to help facilitate the funding of this event. Just for people who are salaried, there are tokens also available for the unwaged people to get to this event and back through the TTC system, and you can ask for those tokens just at the desk that's set up in the back of the room there. So then there's a little box there for the donations. So tokens available for the unwaged. We've asked also that you all sign in. If you didn't get a chance to do that, please do sign in and leave your email address as well so that we can notify you about the future events that we have and we can easily contact you. And we try to build up our distribution list so it's easy to let people know what we're doing. And tell your colleagues and friends about this event as well. And eventually, if this podcast works well, we'll try to make it available online, live, and the recording for people who aren't able to attend in person. Today we have a great lineup of keynotes, which I'm not going to introduce them. They seem to multiply. The last round we had 2 keynotes. Now we have 4, which is great. More is always better. And so the last thing I want to mention before I pass it on to Iggy Cosney, who's going to introduce the keynotes, is I want to thank all the people behind the scenes who have helped make this happen, particularly Kathy Papayeva, who's sitting over there. KJ Shabra is right beside her. Sabrina Panima, where are you, Sabrina? She's at the desk over there. And then Andrew Poston's also helping out with the roaming mic. So it takes a lot of work to make this all happen. They've been working behind for quite a few months, testing out the podcast stuff here. So I really want to thank them for all their efforts. And then, yes, thank you. And I'll pass it now on to Iggy, who is going to introduce the keynote.
It's a bit quiet when Amelia was speaking. Can everyone hear? Yeah? Okay. So hello. It's my great pleasure to introduce our speakers for today, and I'm introducing them in the order that they will be speaking in. So Katherine Lippel is the first speaker, and she is chair and professor in the Faculty of Law at the University of Ottawa, and she specializes in occupational health and safety law, including issues related to workers' compensation. Next, we'll have Joan Eakin, and she is Professor Emerita at the Dalla School of Public Health at the University of Toronto, and her research focuses on the social dimensions of work and health, including the occupational health and safety system. Next, we'll hear from Linn Holness, and she's a professor at the University of Toronto and a physician at St. Michael's Hospital. And her research focuses on occupational disease and its prevention and also health services. And then finally, we have Howse, and she is a PhD candidate at the Dalla School of Public Health at the University of Toronto. And her dissertation examines compensation claiming processes from the perspective of injured workers. So I guess I'll ask our speakers to come up, or the first speaker to come up. Katherine, you might want to, you don't want to? I have. Good. I don't, we don't. Thanks, Emin. Okay, thanks, Iggy, and thanks, Emin, for the introduction, and hello. There's a lot of people here. My colleagues haven't seen that the room is really quite full, and we're very pleased to have so many people who are interested, and very pleased to say hi to Cyberspace Steve and his colleagues. I don't quite know where you are. I guess you're in the camera there. But in any case, we're very pleased to be here to be able to share with you some of the results of our study. I'm going to talk a little bit about the study, where this came from before I actually get rolling in terms of the study. There's three things I want to tell you. First of all, the study came out of work we were doing when RACWI, everybody remembers RACWI, when RACWI was running, and we started off, and I'm from Quebec, and I've been studying workers' compensation in Quebec for 30 years. And we did a focus group with some injured workers in Ontario, and I was surprised at how the workers were not angry with doctors in the same way that our workers in Quebec, I've done many, many focus groups and many individual interviews, and really the targets of rage in some cases in Quebec were really doctors. And so I thought that was interesting, and I talked to Joan about why would that be, and we started thinking about, what would we look at if we were interested in the role of doctors in compensation systems. So that was like the spark that led to a whole lot of work, and I will not go into detail on the number of meetings and discussions and grant applications, et cetera, that we've put together in relation to this. But that's where it started. It started with RACWI, and it started with this sort of impression that the workers in Ontario didn't perceive doctors in the same way as the workers in Quebec had perceived doctors, and we wanted to know, what is it in the systems that could explain this discrepancy? So that's where it came from. The other thing I should tell you is that what we're presenting today is just a glimpse of our results. We have a huge amount of information to share. For the moment, we're sharing a few elements with you, but there will be much more. And as Iggy said, I'm the first speaker, but I'm going to keep popping back like the Ever-Ready Unity Buddy or whatever they call them in English Canada, because Joan's going to talk, and then I'm going to come back, and then we will finish with Linn and then Dana. Now I'm going to move into the gatekeeping roles, and for those of you who are on the ground, you know this instinctively perhaps, but it's extremely important to realize that the concept of physician or doctor is not monolithic. It's not the relationship of injured workers to all doctors. Doctors have many different hats, and both in terms of the profession, because you can have a family physician, but you can have a specialist, or in terms of specialties, a physiatrist is not an orthopedic surgeon. Issues that are going to come out of a challenge in a context of dermatitis are going to be completely different from the types of issues that a physiatrist is going to face, because the types of diseases that you're looking at or the types of injuries that you're going to look at are going to create different experiences for those doctors just because of the nature of the disease. And I won't go into detail on that, but in our interviews it comes out quite clearly that specialists in dermatitis in Quebec, for instance, will not be challenged half as much as the physiatrist, because the physiatrist is looking at musculoskeletal disorders, whereas dermatitis, it shows. So nobody's going to say you don't have a rash. You can show it and you say, I have a rash, and then that's the end of that. So the experience of those docs are going to be quite different from the other specialists in the same jurisdiction who are looking at different body parts and different paradigms in terms of proving proving disability or proving the injury itself or the diagnosis. So on the left hand, that's sort of the types of practice that you could have in terms of specialty versus general practitioner and the different types of specialties. And you have to remember that when you're reading literature that's studying doctors. And unfortunately, they don't always pay attention to that. You know, doctors sometimes get treated as if it's one variable, and there's a lot of facets to them. But we also have to look at their functions, and this is extremely important if you want to understand what we're looking at, which is the role of doctors in compensation systems. So you've got treating physicians, people who are treating the worker. It's as simple as that, people who are treating the worker. You have something that in English Canada and America is called independent medical examiners, and it took us at the end, I'll come back to this, but in French we'd call them médecins experts, people who are paid money to do an evaluation and expertise on somebody. So just in the first months of our project, I couldn't figure out, I mean, they're not independent, they're paid by the board. Why? And so, and we don't call them that in Quebec, we call them something different. We call them experts, and they have their own issues. But then you have to pay attention to these independent medical examiners. Who are they paid by? And they can be paid by the insurer, they can be paid by the employer, they can be paid by the worker. If you're going, certainly in Quebec, if you're going into appeal and you want an evaluation of the causation of your disability, you're going to pay quite a lot of money to an expert to try to figure out if the working conditions to which you were exposed caused your disease or your injury. Then beyond that, those are the so-called IMEs, the independent medical examiners. You have insurer doctors, in-house doctors at the WSIB, or in-house doctors at Liberty Mutual if you're in the U.S. You have company doctors who work in plants. You have them historically a lot more than you do today, but the people who are actually working in Hydro One or working in Hydro-Québec. You have adjudicating doctors, and there's a question mark here. Adjudicating doctors means just, the term means a doctor who's making a decision about something, is a decision maker. And there's some debate as to whether we still have those folk. It used to be, historically, that boards would have doctors who would make the call within the board to say that's compensable, that's not compensable. That would be an adjudicating doctor. In Quebec, we have in the appeal tribunal doctors who sit on the tribunal, but they don't have a vote. So they're not technically adjudicating, but you ask any injured worker who those folks are, and they think they're part of the tribunal because they're informing the tribunal about what's going on. So they're sort of judges, but not really. And then finally, we have public health doctors who are supposed to be in pink, but I'm sure you can't see that, because you don't seem to have them at all in Ontario in the context of workers' comp, whereas our public health doctor network in Quebec plays a very important role in occupational health and safety, including return to work and including, on some cases, in terms of workers' compensation. So we don't have the same folk in both provinces. And now I'm going to remove what I can't see, so somebody else is going to have to remove it because I don't know where it went, because it has to go on Joan. You see what I mean? Yes. Otherwise I can't leave. Good. Good luck.
Well, I might put it, can I put it down? I vanish when I get behind a podium. All right, so now I want to talk a little bit about the sources of data that we have used in our project. they're multiple and they're varied. We use lots of different kinds of data. First, here, in order to do classic legal analysis, our data included compensation legislation, cases, policy documentation, and so on that were used for legal analysis. And we used the research literature, of course, as you've already heard through Katherine, in the usual ways to inform our project and how we think about it. But we also use the literature as data themselves. For example, features of the literature, the conceptualization, how the project was designed, the interpretation they make of it. We use them in many respects as representations of how of matters of interest to us, how things were seen out there by other people. In other words, we use them as data to inform, along with our other kinds of data that we use. Now, the main data for our research included those from an empirical study we did, and consisted of qualitative data from individual interviews and focus groups. And also we used data from our own earlier studies that was relevant to the project. And we used a wide variety of documentary data, including things like administrative forms, websites, online discussion groups, chat rooms, that kind of stuff as data in our study as well. So you can see here who we interviewed for the empirical study. In Ontario, on the left side, we held focus groups and individual interviews with healthcare providers, people like psychologists, chiropractors, physiotherapists, and rehabilitation specialists, and also with workers and with workers' legal representatives. We also held individual interviews with a couple of compensation board administrators and with 12 physicians in different positions and specialties. We also extracted data relevant to doctors from interviews from such as differences in language, and Katherine has already mentioned a difference in how we think about independent medical examiners, the words we use for it, and so on. And so we were interested in the different ways in which things around physicians, what they told us about physicians as well. So we tried to link these things. Might make for the system, for doctors, and of course, ultimately, by extension, for workers. The primary method of our comparative analysis was, oops, I went back. I did that last time too, I'm not paying attention, sorry. So the primary method of our comparative analysis was through what I called, and I just labeled it this, the dialogue method, which I once explained to my colleagues who were not familiar with it, is a dressed up methodological label for yakking. We talked and talked and talked. But of course you can't call it that if you're going to have a fancy methodological label for something, so it's called the dialogue method. It consists of constant, detailed, self-critical discussion between the investigators of the data, the analysis, the emerging findings, our interpretations of what's there, making sense of what's there, and constant self-instruction and interrogation of the disciplinary constructs that we each use, because we each come from different places, and we at times didn't understand what each others were saying, or we thought we were talking about the same thing, but in fact we weren't talking about the same thing. So this yakking process was really fundamental to the sense we could make of the data we have. So whatever it's called, and however unorthodox it might be as an approach to scientific production, it was and is an invaluable tool of interdisciplinary and multi-investigator research that capitalizes on our divergent perspectives and capitalizes on our disciplinary depth, and also capitalizes on the potential for group-generated insight and imagination. We also, of course, deployed some of the standard methodological devices of interpretive qualitative analysis, but the dialoguing was the centerpiece, in fact, of our method. So now Katherine is going to come back and will move us on to the findings of these research methods. Oh, yes.
Okay, so the commonalities between the Quebec compensation system and the Ontario compensation system. In Quebec, of course, it's the CSST that manages the system, the equivalent of the WSIB here. So there are some legally similar structures, and both in Ontario and Quebec, the decision as to work-relatedness between an injury or a disease and the working conditions or the conditions that gave rise to the injury, the last word goes to the board, both in Quebec and in Ontario. The board controls causation. The idea being, the idea underpinning that is that in order to determine causation, you need to know not only about the medical issues, but you need to know about the working conditions. And the discourse has, or the official story, if you like, is that doctors, and it's often very true, don't know about working conditions. So the board wants to maintain in both provinces control of the determination of causation, and that also includes determination of residual ability to return. They will see in a minute that what that residual inability is in Quebec belongs to the doctors, but whether that affects your ability to return to work, in other words, conjugating the physical problem, the remaining disability with the working conditions in both provinces, it belongs to the board as such. Anything that's medico-legal causation belongs to the board in both provinces. In both provinces, in terms of the results of what the doctors are telling us, the bureaucratic process, and we're being very euphemistic here, is a source of irritation for the treating physician. And sometimes it's because they're very discreet as well, and they would not go beyond saying it's a source of irritation. But people who are doctors do not like filling in forms, and they don't like filling in forms in Ontario, and they don't like filling in forms in Quebec. In Quebec, we call it la paperasse. In Ontario, we call it, all those forms that we have to fill in, and it takes a lot of time. This is a quote from an Ontario doc, where quoted by a worker rep, so we don't know if it's a man or a woman who says this, but the doctor said, there's no room for me to say you cannot work. And that is interesting because that exists in the Ontario form, but in the Quebec form, there is room to say you cannot work. And not only is there room in Quebec to say you cannot work, but the last word for early and safe return to work equivalent in Quebec, the last word for assignation temporaire is with the doctor and the treating physician. So that's a difference. I'm talking about commonalities here, but even within the commonalities, there are differences. Like what's on the form is not the same in Quebec as in Ontario. Nobody likes filling in forms, period, because they don't like filling in forms because they're doctors. They want to treat people. They want to treat as many people as they can. They don't want to be doing paperwork. But then what's on the paperwork, that's where you start seeing the differences that will operate in terms of doctors' experiences as well. I won't go into any more detail on that, but certainly in our study we do. The doctor's gatekeeper role is a source of discomfort for practicing physicians in both provinces. In Ontario, physicians some of the physicians we talked to were insecure about playing that role, saying, well, I don't really know if it's caused by work or not. I'm not really confident in my ability to make the call on that. One of the doctors said, we're really glad that we have other more specialized evaluators for the WSIB who will help us with that, because me as just a general practitioner, I don't know really if I am confident in my own judgment on this question. I don't know how to answer it. But there's also discomfort, not in terms of not making the right decision, but just discomfort in terms of the doctor-patient relationship. And the doctor, in many cases, in both provinces, is, up against a rock and a hard place, as we say, because they don't want to make their patient unhappy. They don't want to make the patient's life worse. If they get cut off benefits, their life will maybe get worse. That's not good for their health. On the other hand, they don't see medically how they can justify something. So that discomfort could be reflected in that kind of difficulty of trying to say something because you know that your patient really counts on you to do something. It's going to affect your relationship in a way that's different than if you're just treating an ordinary Medicare patient where you just treat the person and you don't have to figure out what's causing it, because it doesn't really matter what's causing it if you want to treat it in many, many cases. It does if it's a dermatitis, but in a lot of cases, with a bad back, if you're just treating somebody with a bad back and causation is irrelevant, then you can just treat the person. And therefore, the discomfort is there when the gatekeeping role starts up, where you have to say, well, yes, this goes into this slot, it's covered under disability insurance, or it's not. A separate issue, completely separate issue, and that came out at many levels in both provinces, was the lack of feedback. And this is true of treating physicians, but it's also true of expert witnesses who testify in court, and then we never know who won. So they go in and they don't know whether they did a good job, they don't know whether they convinced the judge, and if we're talking about treating physicians, be they specialists or general practitioners, they write something on the form and then they never know what happens, especially if it's not somebody who knows the patient well and they don't see the patient again. They don't get the feedback to know what's going on, and that is a source of discomfort as well in many cases. They feel sort of, I don't want to put words in their mouth, but they feel that they're sort of playing a role in the process, but they're not being supported in that role necessarily. In some cases, we can't generalize either because, each interview is different. One thing that is clear both in our interviews, but also from what we know in the comparison of the systems, is that when it's a compensable injury, when it's covered under workers' compensation, there are more therapeutic choices, both in Quebec and in Ontario. So I'll give you an example. If you want to prescribe treatment by a psychologist or treatment by a physiotherapist, certainly in Quebec, if you're in the public system, you wait for months and months and months to see the psychologist for free because they're not covered under Medicare unless you go through the public system, and there's a very long waiting list. Same thing, and it depends on the period, because we're getting contradictory messages on this, but for surgery, it used to be that a workers' compensation claim would be fast-tracked. Because you want to get the person back to work quickly, so you jump the queue. That came out of my old study in Quebec, and what I've been told in this study in Quebec is that they've stopped that. For surgery, they're not fast-tracking anymore, but it depends on which period that you're looking at. There is a period where there's fast-tracking. There's also more access to tests, and this is good and bad, in the sense that if you have to prove that there's something wrong with your worker, you might feel the necessity of doing an MRI that is not medically justified, but it's just that you have to prove it, and you can't prove it without doing this really expensive test. Whereas if it was just a question of wanting to treat the person, you wouldn't need to do that test. And Terry Eisen, in his very early work, documented this very well, the unnecessary tests that injured workers end up having to have because we have to prove that there's actually something wrong. We need evidence in the legal sense. So in terms of commonalities, that's true in both places. Other commonalities that we found, and this is kind of ironic because the idea that money is important certainly never occurred to me until I did this study, which might be a reflection on me and not a reflection on anything else, but I just never thought, money, really? And it became rapidly extremely important in both provinces. The role of money in the experiences of the doctors. But the nature of the importance was very different from one province to the other. In Quebec, there is a very, my injured workers focus group calls it l'industrie de la contestation, the industry of contestation, where there are doctors who are making a huge amount of money. And one of the first interviews I did was an orthopedic surgeon who had spent his life practicing in the hospital doing operations under very bad conditions. He described like almost mass warlike conditions in the hospitals in Quebec. And he says, and now they're paying me twice as much just to write reports. I mean, this is great, you know. So he stopped practicing because he was making a huge amount of money with the evaluations, and he wasn't making very much money being an orthopedic surgeon. But the mechanisms between Quebec and Ontario differed significantly. Like, I'll give you an example of the difference in terms of that. We can, money actually came out in Ontario, and it's in the literature in Iggy's study, among others, and also in our focus groups in Ontario, that doctors aren't paid enough. Several people told us doctors in Ontario who are treating injured workers are not paid enough for the work that it involves. In Quebec, one of my interviews said, well, what's nice about injured workers is that they don't go into your quota. They have a billing quota under Medicare, but if you're treating an injured worker, because it's the CSST that's paying, that you can go beyond your billing quota. So it really is interesting to see that money counts everywhere. Almost every interview there's something about money. But how it counts in the different provinces is different. It can either be incentive to treat an injured worker or to not treat an injured worker. But money, if you're going to study doctors, one of my take-home messages is don't forget about the money. The sources of funding differed in a very significant way as well, in the sense that the board in Ontario pays for evaluations quite a lot, but we didn't hear a lot about evaluations being paid for by employers, where there are some, but in terms of proportions, what we heard about a lot in Quebec was that employers were paying huge amounts of money for medical evaluations. They had doctors on retainer regularly to manage every single claim, whereas in Ontario it was much more board-paid doctors than employer-paid doctors. The disparities in who could access expert evidence differed as well. There is no Office of the Worker Advisor in Quebec. There is no funding for paying for an expert evaluation in Quebec for workers. costs a fortune. I've seen $12,000 for one evaluation. That was paid for by a union. If you're not unionized, there is no fund. And in some cases, there could be as many as 32 expert opinions in a file in Quebec, and each one of them paid for by somebody. Now guess how many are for which side. So anyway, I'm not going to belabor that point. So that's in terms of similarities, and there's similarities. Money is similar, but how it plays out is different. Now we're looking at differences. And we're doing okay for time? Okay. This is where I get legal on you. So as in French, I would say attachez votre tuque, tie on your bonnet, because we're going to go legal. There's a huge difference between Quebec and Ontario, and if you don't understand this, you don't understand our study. What's really important in Quebec is that the law since 1985 determines that the treating physician, and there's a whole lot of case law on who that would be, but the person who is treating the worker, be it a specialist or a general practitioner, their opinion is binding on the board with regard to the 5 issues that you have up here on the slide: diagnosis, treatment, date of maximum medical recovery, functional limitations, and permanent impairment. Their opinion also on early and safe return to work is binding on the board. So that the fact that those opinions are binding colors the whole process in Quebec and the roles of doctors in Quebec. Because in Ontario, the opinions of doctors are not binding on the board ever, on anything. That doesn't mean that they're irrelevant. And I think my next slide will get into more detail on this. Because it's binding in Quebec, what does that mean? If, for instance, my treating physician says that I have a herniated disc and I will not be consolidated at least for the next 2 weeks, that's the type of information you have on that form. If the board doesn't like that, or for the next 3 months, the doctor can put the date he wants to or she wants to put on. If the board says, this doesn't make sense, we don't think this is a herniated disc, or if the employer says we don't think this is a herniated disc, they can't just ignore the opinion, but they can ask for a second opinion. So the worker has to, in Quebec, go see the doctor chosen by the board or chosen by the employer or chosen by both, because they both have the right to get a second opinion, for every single paper the treating physician fills in. So you can end up being called to 3 doctors many, many, many times in Quebec. And employers they have the right to have workers evaluated. The worker will lose his or her benefits if they don't go to the medical evaluation requested by the employer. And in Quebec, contrary to Ontario, the employer doesn't have to ask permission from anybody to order the worker to go to a medical evaluation. And the way the process works in Quebec is that either the employer or the board gets this second opinion, and then the board goes back with the second opinion to the treating physician and said, well, Dr. So-and-so said this, what do you think about this? And then the treating physician can either say, I'm sticking to my guns here, I really believe what I wrote, or the doctor can say, well, I hadn't thought about that, and he's probably right or she's right, and I'm going to change my opinion. The worker in Quebec cannot legally contest his own doctor's evaluation. So if his doctor changes his or her mind, the worker is bound by this and can't say, well, he's wrong. He said it was a herniated disc. Now he says it's a lumbar sprain. I think it's a herniated disc. The worker does not have the right of appeal on that issue. Whereas in Ontario, of course, the worker can contest anything he likes or she likes to contest on medical issues. Employers may ask for a second opinion, but from my understanding is that it's a lot less common for an employer to ask for a second opinion and ask for a worker to be evaluated by the employer doctor. And the employer, according to my understanding of the policy, and I'm always careful when I see folks from the Office of the Worker Advisor in the room, the worker can say, I don't want to be evaluated, and then the board will have to step in and figure out whether the worker has to go or not. So it's a little bit more convoluted for the employer to get a second opinion in Ontario than in Quebec, but for the vast majority of folk in Quebec, nobody contests, so that the fact that the opinion is binding almost everybody we spoke to said, don't change that, it's really important. It's really important that the treating physician's opinion is binding because my worker gets his treatment immediately. He doesn't have to wait around for the board to decide whether physiotherapy is called for or not. So the effect, some of the effects, and we have lots of material on this, but this is one quote from Ontario, and I'll read it out just in case people from far away can't see the slides, I'm not sure. But this is, in Ontario, we got the feeling often that doctors felt ignored. So this is one doc who says, I will put on a form that I don't feel that the patient can work, and the patient reports back that workman's compensation says they can work, and they're cutting them off. Sometimes I just feel that they are asking my opinion, they are paying me for my opinion, and they are ignoring my opinion. So in Quebec, you can't ignore the treating physician's opinion. The only thing you can do if you don't like it about the, for instance, the functional limitations or the date of consolidation, the maximum medical recovery, if the board doesn't like the decision of the doctor in relation to that, the opinion of the doctor, the only thing they can do is get this second opinion that I just described. So how do the Quebec doctors feel about that? And I have two slides in French. I kept them in French. I'll translate them for you, but I thought you would like to see the texture of the language for those of you who read French. So this is a specialist. This is a specialist speaking. And she's saying, I'm not an expert doctor. So she's a specialist, but in her discourse, she's not an expert doctor because she doesn't get paid for her opinions and go into court. She's not an expert, but she's a specialist. I'm only a treating physician. I understand really well that you can have differences of opinion between doctors and between expert doctors, les médecins experts, and so these people who are giving their second opinions and getting paid money for them. But I find it very difficult when we read the expertise, the written opinion of this colleague from another specialty, and I won't say which specialty she was from, but there are classic conflicts between specialties in certain fields, and that opinion, nous descendre, really tries to shoot us down. It's a very forceful language. And she goes on, I really find, and she was almost in tears, and she said, I really find that it lacks professionalism. And often the patient is sort of stuck in the middle because it creates a malaise with the patient because the patient, he's being told that he's in between two waters or in the rock and the hard. He's been two different opinions. And it's one thing to disagree with the treating physician, but lacking professionalism and attacking the other person, that's something else. Written in really big letters, written in bold and souligné en gras. Like she was really upset, this woman. It was underlined in bold. It shouldn't be like that. And it creates really unnecessary malaise and discomfort for me as a practicing physician. So they're being shot at and they're being attacked and they're feeling like they're being attacked in this particular case, but several people who were speaking as treating physicians would report that. So that's a system effect as well. Briefly, if we get to the appeal level, very different systems. And it's interesting because I just read in preparing this, I saw the latest annual report of WSIB, and there's the Rockies or the Alps or something are on the cover, and they said this huge mountain of appeals. We find 5,854 new appeals. Well, in Quebec, it was 30,026. So, you know, on se compare, on se conseille. But I have a feeling people don't compare their systems. So in Quebec, first of all, doctors, there are 20.5 doctors paid to sit on the tribunal. They don't have a decision-making power, but they're there to advise the judge, if the judge wants one, to be there, and if they're available, because there's not enough of them to go around. In Quebec, the tribunal does not pay expert witnesses ever. It's very frequent testimony and production of expert opinions paid for by employers, the CSST, or the worker. I gave you my example before. One case, there were 32 different expert opinions like that. In Ontario, what you have, there are, to the best of my knowledge, no doctors on staff at WSIB, but WSIB can pay for an expert opinion to inform the court on a specific issue. I remember reading one on multiple chemical sensitivities many years ago and saying, gee, I wish somebody would pay Quebec doctors to evaluate multiple chemical sensitivities. We need this kind of evaluation because we don't have access to it. We also don't have the equivalent of OCAL. And I'm not going to explain what OCAL is here because you guys know, but we don't have it. And the parties may produce expert opinions in Ontario if they want to. And you also have the Office of the Worker Advisor, which I don't know whether you pay for the expert opinions, but in the discussion I suspect somebody's going to tell us. I probably should know that, but in any case I don't. So another issue that is different, what we call paper doctors. So what are paper doctors? Paper doctors are doctors who look at the file and give an opinion. And historically in Quebec, before our 1985 law, they were denounced in Quebec, they were prevalent. They never examined the worker, they just looked at the file and they say, okay, this guy, it's not caused by work, or this guy, you know, it says that he's got this, but I don't think, I'm looking at this x-ray and I don't think that's what he's got. But they don't actually examine the worker. Much more common in Ontario to have what we call paper doctors, or evaluations of files, than it is in Quebec when we're looking in 2015 or 2014. There are still internal WSIB doctors. There's not that many anymore, apparently, compared to what it used to be 5 or 10 years ago. But there are still doctors who will look at the file and advise the frontline adjudicator in some cases. And there's a lot of what we call piecework, external review of files. This is the new system of evaluation. It's much less common in Quebec. That whole rigmarole of contesting and second opinions and going to a third opinion and adjudication, the law provides that in each case you have to examine the worker. So workers get examined a lot more in Quebec, and that's good and bad depending on a bunch of things. But the worker, you know, we're not looking at the file, we're looking at the worker. The CSST doctors occasionally will give a frontline staff opinions on work-relatedness without examining the workers, particularly for occupational disease. But otherwise, they're very reticent to even talk to the treating physician because it's a highly medical, legal charged atmosphere in Quebec. So this is my point. Again, one of the doctors said to us, you know, it was really difficult because I knew my patient was going to perhaps try to commit suicide. I didn't know if I could call the agent. The agent didn't think she could call me. Finally, I called her and she said, I'm really glad you called because I'm not allowed to call you. So, you know, in terms of really actually trying to help the worker, there are constraints in terms of communication between doctors and the board in Quebec. So I'm almost done in terms of my bit. In terms of key points, the short answer is jurisdiction matters. And this is true for researchers, and it's true for anybody who wants to understand the system. Systems are profoundly different even in two Canadian provinces. So imagine what it's like when you're reading a study from the Netherlands about the role of doctors. It's a completely different story that you're looking at. Second take-home message, doctors are not monolithic category. Really where the social location of the doctor is, even where their specialty is key to the experience. And if you don't really look at the details, you're going to miss a lot of important information. And money as a mechanism operates differently between and within the provinces that I've touched on. And I believe now, I have one more slide and then I don't talk to you anymore, and then my colleagues will take over. But in terms of reflections, what we wanted to do in this piece, each from our own disciplinary perspective and geographical location, in my case, have 1 or 2 slides of what we got from the study itself. And for me, well, I'm a lawyer, I guess you figured that by now. And this is what I tell my students also who are in disability prevention. The system matters. You can't take a study from Australia and apply it to Quebec without understanding the context in which the study is done. And that isn't done very often in the literature. And so that people start generalizing from a study done in the Netherlands or in Sweden where the causation isn't even relevant. And all of a sudden they're saying, well, in Sweden they showed that doctors do this and we should do it like that, without looking at the system. So the details of the system are very, very important. And most researchers, especially in the health sciences, don't have an idea of their own systems. Second message for me, and I consider myself a specialist of my system, but you need to see another system in detail to understand your own system. And I really learned an awful lot about my system by saying, you don't do that? And our good yaks, the 4 of us together, we spent, hours of amazement in comparing our different systems. And then finally, in terms of cultural differences, in terms of language, first of all, this is more personal, but I have this stupid idea that everybody speaks French. And so do not do a qualitative analysis of 40 interviews in French with a team when not everybody speaks French, because it gets a little bit more complicated and you have to factor that in. But it's also that we have different words, as Joan says, completely different words that are culturally different, far less polite in Quebec, far more blunt. My interviews with my Quebec doctors, we got on like a house on fire, and Joan, the first time she read my transcript, she said, "Is he angry with you?" I said, no, that's how we talk, you know. So it's really culturally different, and different systems are, even though the rules can be similar, the way people live them out are very, very different. So you have to really match the experiences through the qualitative study with the understanding of the system to really put all of that together to understand really what's going on.
As Iggy mentioned in introducing me, my doctoral research is looking at the understandings and practices of injured workers, with specifically injured workers with sort of problematic, drawn-out claims. And many of those injured workers are very much engaged in the injured worker community, so they have some awareness about the system and about the compensation process. So I want you to bear that in mind as I kind of walk through my reflections. So because my research is focusing on this, I've been particularly interested in the findings of this study on doctors that are relevant to and indeed echoed in the data that came from my interviews with injured workers. So for my piece today, I decided to reflect on why doctors matter from the perspective of injured workers. I'm going to focus on 3 key findings from my injured worker study that stood out or sounded familiar to me as the analysis for this study began to take shape. So first off, the value of the doctor's report came up time and again in my interviews with injured workers. So they talked about, of course, gaining access to health care. They talked about they really saw the doctors being sometimes really central to the success of their claim. They talked about that objective medical evidence that the doctor provides, such as x-rays, MRIs, ultrasounds, as really proving that their condition is real and as being a necessary piece of their claim file. One worker referred to it as support documentation that you had to have to substantiate what you said in your claim. And for many workers, it was the WSIB Form 8, the doctor's report, that initiated their claim with the board. And as one worker noted, as you can see in this quote, her doctor's report, which clearly attributed her injury to her work, really clinched her claim for her, really clinched her case. But the workers also indicate that the content and the specific details contained within those reports was really important to the success of their claim. And as you can see by this second quote here, this worker says, you have to put it in very, very clear words. It has to be written, the work injury caused her condition, her present condition. And if it isn't in there that way, they take it for what they want to interpret from it. And they, of course, they mean the WSIB. And also in this vein of the value of doctor's report, it was interesting that while workers understood the value or the importance of that report, they also understood, as Katherine mentioned earlier, that the doctor's report in Ontario is oftentimes can be contested by the employer and maybe ignored by the board and not used in the adjudication of the claim. And as you can see by this quote here, this is frustrating for workers and oftentimes can be problematic. So this worker says, based on the congenital defect, the employer persuaded the WSIB that no, in fact, my claim should not be approved. So, and the thing was that the WSIB had that information. I got the doctor's report and everything. I sent it to them. They needed all of that, you know? So anyway, of course, the employer scratched that and said, you know, this is unacceptable. And of course, they don't want to pay out a claim, right? This is connected to sort of the second finding in my injured worker interviews that rang familiar to me when we were working on this study, was that doctors find the WSIB as a source of irritation. And so the workers in my study experienced and were affected by their doctor's annoyance with the WSIB and its claim requirements. Several workers described visiting walk-in clinics and having doctors flat out refuse to take on compensation cases. And as this worker describes, I gave them the same information over and over and over, enough to wallpaper Toronto 50 times. And my doctor got so disgusted with it, he just gave up and he said no more. The third finding that really resonated with me as we analyzed the data from the doctor's study is that injured workers seem to see their doctors and they see their relationship with their doctor as operating within a larger system. So they don't just see their relationship as happening in a vacuum. They see their doctors as being influenced by other factors than the obvious health or return to work related ones. So for example, workers perceive their doctors as having financial incentives to prescribe particular treatment plans. One worker believed she was being passed around from doctor to doctor so that they all might get a piece of the reimbursement, whether that was from OHIP or the WSIB. She sort of felt they were referring on and on and on to help their fellow doctors out to all get a piece of this pie. Another described his visits to a specialist as feeling like an assembly line, like he was just being pushed through. And as seen in this quote here, this worker suggests that doctors were financially motivated to prolong treatment unnecessarily. He says, the other side of the coin is doctors are human too. They follow the money trail. So the doctor would say, if I can get you on this program for 12 weeks out of 16 and you feel better in 6, I still want you to come in for the 12. So there's, a survivability of business mental attitude happening there. And finally, workers also perceive doctors as being used by the WSIB to shorten or deny claims. So workers spoke of having to see multiple doctors, and they talked about the problems that can arise from that around conflicting opinions, differing modes of treatment, exacerbation of injuries as a result of that, and so on. And workers perceive this requirement as a board strategy to manipulate the diagnosis and treatment in their favor. A key informant I interviewed, who was a worker representative, sees the board's request for more information as seeking a way to deny the claims, to put up those barriers to approving a claim. And one worker expressed frustration that her specialist's opinion was overruled by a non-treating physician who she felt was unqualified to do so, to make that call. And as you can see in this quote, workers they see the doctors as being on a side. So they're either on the worker's side or they're working for the board, and they see the board as being biased. The board doctors, or those doctors being preferred by the board, as biased. So this worker says, the WSIB has a list of doctors that they choose because those doctors sway their way, okay? It's a list of their own doctors. These doctors get paid to do these things. My doctor even told me that she was approached years ago, and she wouldn't. Nope, because you can't be as impartial as you want to be. So that was just some findings that rang true or resonated with me as we were going through this doctor's project. And I thought it was really interesting to see that some of these dimensions of the doctor's gatekeeping role that came up in our study of doctors were also echoed in the injured worker interviews that I conducted. So it's interesting for me to see that injured workers have an awareness around the doctor's role and the dimensions of that gatekeeping role, and that they are sometimes affected by those issues as well. So that's the end of our formal presentation, and just before we carry on, I want to thank certainly all the participants in our study, as well as the partnering universities, University of Ottawa, University of Toronto, the Research Action Alliance on the Consequences of Work Injury, and our funders, the Social Sciences and Humanity Research Council, SHRC.
Who is next here? John's going to do the introduction for the next section of today's session.
Okay, so, well, thanks very much, Joan, Linn, Katherine, and Dana. That was absolutely fascinating, and I look forward to reading more about this. It's my pleasure to introduce the next section of our presentation today, which is the voice of injured workers, and it really follows from what Dana was talking about in her interviews with injured workers. Certainly the research that we present at these Bancroft sessions gives a voice to injured workers by looking carefully at the experience of many injured workers and analyzing it and reporting it and making use of it. But of course, as Dana mentioned, it's also very important to hear actually directly from injured workers. And so I'd like to call up Daniela Ruiz and Willie Noyles to join me. Now, do we have a microphone that reaches the table over there, maybe? Okay, well, we'll start from here, and maybe I'll, okay. This one right here. Okay, good. So, I'll ask Danielle and Willie to join me over here. So let me just introduce our presenters today. Here in Toronto. She was injured doing this work in 2013, and so she spent some time recently going through the system that we've just heard about and has the experience of dealing with doctors in the workers' compensation system. Daniela is a member of the Injured Workers Action for Justice group, which is an injured worker group which meets at the IAVGO Community Legal Clinic. And Willie suffered a permanent injury back in the year 2000 when he was working for a temporary health agency. And Willie has since then gone on to become a founding member of the Niagara Injured Worker Center, and he's also the chair of the board of the Community Legal Clinic there in St. Catharines. And so, welcome and thank you very much for sharing some of your experiences with the doctors in the workers' compensation system. Maybe I'll start with Daniela, if you like.
Sure. Thank you so much. It's been great to learn so much and to be part of this. I mean, it was an experience that changed my life. And as well, you know, I think you really know that it changes your life. And especially at a young age, right? And, you know, being, you know, in this situation at a young age, certainly, you know, put many doctors' eyes on me, right? So, you know, I had very, very much, you know, experience and familiarized with different doctors, different specialists. I went from all the steps that WSIB takes with injured workers. So I went from my family doctor diagnosis, then with other doctors, specialists. I went to MRIs, I went to all the exams. Then I was with a physiotherapist for a few months, which I realized the important role in, you know, in these specialties and how they impact your recovery. And so, as well, you know, WSIB role in accepting these claims and accepting, you know, the treatment. And, you know, I realized, too, the, you know, importance of the right treatment. So, because being in the physiotherapy for a certain time, not seeing recovery, realized that it wasn't what I needed. So, I was the one who appealed, saying, you know, this is not changing, so I need something different. I need another specialist, right? I need to recover now. If not, it's going to take years. So finally, WSIB accepted, and I was referred to a specialty clinic or rehabilitation clinic by the WSIB. And so they work for WSIB. They're created by WSIB. And so in there, you know, I realized I had 3 expert doctors looking at me, 3 different opinions. And so it is quite, you know, impacting, you know, to see how much attention you get, but not necessarily in how you're treated, but in reports. Because mainly what they did is just write reports, write forms, and inform WSIB and everything, you know, in the process, along the process. So, yeah, I mean, details matter a lot. Quantitative and qualitative, reports and how many times you get the same treatment. And actually, are they, you know, asking the right questions to you? I mean, are you getting better or not? Is it the right treatment? And so, yeah, it's very challenging. So I think that's what I wanted to say. And then...
Okay, thank you, Daniela. And I can definitely agree that definitely the work injury changes your life completely. Where the path I'm on today is not the path I'd even looked at or even contemplated, because just before the accident, I had been accepted for a job offer up in the north, writing for a local newspaper there. So that was what I'd gone to school for. And although I do still write today, when I got injured, there was no way I was going to be able to take that job. So I had to kindly say no, but that was the first change that I noticed. And with me, it was an accident on a site working for a flower grower. So I was carrying this big tray of flowers, slipped on some water that was on a slick concrete thing, hit a trailer hitch with the ankle, and just went sailing and came down on my knee, which, of course, there was nothing left to the knee at that point. And so they rushed me into the hospital, and luckily I got a good osteopath who was there, or what are they called? Anyway, the guys that work on the bones. Orthopedic surgeon, that's the word. And he was able to get the surgery done relatively quickly. And he figured after the surgery, okay, no problem. You'll be up and running around in about 3 or 4 months. The worst thing is you won't be able to kneel at church. And I just said, well, that's no problem because I don't really go to church anyway. What we didn't count on was that I would end up getting RSD, or what's now called CRPS, reflex sympathetic dystrophy, or complex regional pain syndrome. And because you only saw the specialist or the orthopedic surgeon when you had an appointment, therefore there was a number of months that went by before we actually knew why I had the pain I had, why my leg was twice the size of the other one, why it was discolored, the whole bit. And finally, when he saw me, and I had shorts on because it was still September, I believe, at that point, and he said, oh, you've got RSD. I think we're going to have to get you in to be treated. And up until then, like, the family doctor didn't know what was going on, so he just kept upping and upping and upping the amount of drugs he was giving me to treat the pain. So thankfully they got me in to see an anesthetist who started with nerve block and that. Unfortunately, though, because there had been such a long delay, it didn't work. So I'm stuck with this for life. But WSIB, telling me that they were helping me, sent me to this premier pain specialist at Sunnybrook. Well, in any pain people I've talked to, they've never heard of this guy, so he can't be a premier pain specialist, but he looked at me for about 10, 20 minutes, sent me home. The report he gave to WSIB was that I had CRPS, but it was burning out. There is no such thing as CRPS burning out. But that was the diagnosis he came up with. Well, that was 15 years ago, and it's still burning out, I guess. Yeah. That was frustrating, was that some guy that's paid by WSIB can give an opinion like that can really change your case. And unfortunately, at the time, I really didn't know what my rights were as a worker. And that's probably part of the reason I'm so involved with our Injured Worker Center now is that I don't want to see another injured worker go through what I went through, the ignorance that basically I was in at that time. And the one thing, we ran into a doctor at Social Justice Forum that Brock holds each year in January, and he was telling us that the one frustration he has is that he sends in all these forms because he's trying to treat his patients, and he says they're basically ignored. He says, why am I writing these reports? Because nobody's listening to them. My patients are experiencing this. And the other complaint he had, apparently, is that WSIB takes their time in reimbursing doctors. And I didn't realize that. And he said there's a part of him that would just rather say, forget it, I'm not treating WSIB patients anymore. But he says, I can't do that to my patients ethically. But he wanted to get involved with our group, and we're definitely going to be trying to bring him in because we need somebody like that. We need a doctor who really wants to fight and try and make a change. Because unfortunately, we have the other kind who work for WSIB, and I'm not going to mention her name, but she's a specialist who treats a lot of people with CRPS, but she also likes to go around and write papers where she says that up to 10% of CRPS patients are malingering. They don't actually have it, they're malingering. She has no facts to back this up, but that's what she's saying out there. And I know our charity that works with CRPS got involved because she had one paper out that was financed by a few different universities, and we put the call out and said, like, have you looked at this report? Have you looked at what she's written? And have you looked at the complete lack of evidence to support this claim of up to 10% are malingering? Somebody like that really upsets me because she's treating injured workers out there and basically helping to deny their claims because she's spreading a whole bunch of phooey. And we had a patient who called into the charity's helpline a few weeks ago, and she was in a situation where WSIB kept referring her to one specialist after another, until finally they got another one who said, it's burning out. And suddenly they didn't have to send her to any more specialists because they got the opinion they wanted. And unfortunately, that's the problem we find as injured workers, is that a lot of times WSIB will send you out until they get the opinion that they want that can help them to deny your claim or lower the amount they have to pay you. And I was looking at the two differences between the two systems, and as an injured worker, it'd be nice if we could find that happy medium between the two systems, because there's some parts I like about the Quebec model, and there's some parts I like about the Ontario model. So if we could take the best of both, it'd be great. But unfortunately, we don't live in that ideal world I'd like to live in some days.
Thanks very much. Thanks, Daniela. Thanks, Willie. Thank you.
Lack of starting. Thanks. So I'd also like to say thank you very much to Daniela and Willie. And Willie, you provided a nice segue into our next panel presentation, where we're going to be having 4 people who deserve wonderful introductions, but due to shortness of time, they'll just get brief ones, where we're asking them to reflect on what they've heard today, bringing in their own experiences and thoughts, and to make any comments, if they have any, about how we can use what we've heard, and any thoughts about any future kind of research. So, could I ask the panel members to come on up, please? as they're arriving, I'll begin to introduce them, and really they are all very special people. Catherine Fennick. Catherine, I'm going to ask you to go first. Catherine Fennick was also injured as a young woman and has been forced, in a way, to live the life of an injured worker since then. But she's done very well with that. Many attributes, but one of them is she is actually the founder of what is now International Repetitive Strain Injury Day. Then we have David Chesney. David is from the Canadian Union of Public Employees. He's a national rep who specializes in workers' compensation. He's also the chair of the board of directors of OCAL. And he plays many other roles. And he's part of a team that meets with Elizabeth Whitmer, the chair of our WCB here, WSIB, for what that's worth. Then we have Laura Leninsky. Laura works at Injured Workers Consultants and an advocate for injured workers. And she is very involved in casework, knows the lots of details about what happens to injured workers vis-a-vis the WCB and physicians, and is often involved in writing research papers. And then we have Dr. Morty Mamalek, and Dr. Mamalek is a psychiatrist who has many injured workers as his patients, and I can say from personal experience that he is one of those doctors who goes beyond the call of duty to help his patients out. So, Catherine, could we ask you to begin?
Thank you. So I was asked to give my what struck me from this, and my head's kind of spinning right now because there was so much information and wondering, whether the Quebec system is better versus the Ontario system. I was surprised that Quebec workers are angry at the doctors at the outset, but I guess we see why, given the role that the Quebec doctors have. When I got injured was 21 years ago, and I know in Ontario our anger is at board doctors because there's something so incredibly frustrating about having somebody who has never seen you make a determination about your health. And early on in my experience as an injured worker, I remember waking up one morning and my left arm just felt completely dead, like there was no blood in it. And I actually had to use my right arm to lift my left arm and move it across the bed. And it was really scary. That was the first time it had ever been that bad. And that morning I got a call from my adjudicator who told me that his board doctor had told him that my arm had healed. And I'm thinking, how the hell can you say my arm has healed? And his reasoning was there wasn't any recent medical. And I said, well, you've never asked for any. If you'd asked for it, I would have provided it. They had sent me the forms earlier on, and I always took every form to the doctor, but in this case, they hadn't given me anything, and they suddenly decided that my arm had healed on one of the worst days that I had had up to that point. So that was very frustrating. In the Quebec system, seeing that the treating physician's opinion is binding on those 5 issues, that sounds great, but then it scares me, the thought that as an injured worker you can't appeal it. And also this whole idea of this assembly line of IMEs. There's something, I've been to a couple of IMEs, and there's something, it just doesn't sit right with me as a person that I have to subject my body to being examined by somebody to prove something. And the IMEs that I went to were from my employer. So in that case, I don't know if the worker has any right to challenge who the IME doctor is, because that was at least something that I was able to do as a unionized worker, was to challenge who I was being sent to. And we did that on the basis of their CVs, that the employer was choosing doctors who just weren't experienced in the field. And the first IME that I was sent to was, the doctor was the team doctor for the Toronto Raptors. And I said, if I was a professional basketball player, great, I would go to this guy, but I am not a professional basketball player. So we actually found somebody who had occupational health experience dealing with RSIs, which is my injury, and actually got a good IME report from that doctor because, you know, he couldn't deny that I was actually injured. And I guess, you know, one of the questions I have too is how do treating physicians fit into the whole accommodation process? Because for me, I dealt more with accommodation through grievances, and not, the board wasn't involved at all in my return to work. So, you know, that's where I had a lot of issues with employers rejecting medical, and just making me go back constantly to the doctor to get more and more and more. I guess, you know, the other thing, my experience here with board doctors would be more of, you know, having that person who's never seen you make a decision. I remember early on I was sent to the Downsview Rehab Center, and, you know, the doctor there, I have thoracic outlet syndrome, and when I asked, you know, at the end of the day, what am I supposed to do? Like, I went there for help, and I was told, do what you're doing now, and I looked at him. He said, wear a sweater. I said, there's no blood flow in my arms. My arms are cold because there's no blood flow. Wear a sweater. The next time I was sent actually to the same doctor at a regional evaluation center, he didn't even look at me. So that's kind of, you know, what we're dealing with. So I guess I have 1 minute left. Or I guess for me, like I said, my head is spinning. You know, is the Quebec system better? Is the Ontario system better? I don't know. I mean, the people I encounter, the system's not working for us, you know. In desperation, I actually called the board early on asking for the name of a doctor. So, because my treating doctor just didn't really want to deal with my injury. And I thought, well, you deal with doctors every day. You should know who I could go to, you know, being that naive. So, yeah, I think there's a lot to consider here, and thank you so much for doing this research. It's so important that we understand the critical role that doctors have in the system, because as injured workers, we do rely on what they say, and unfortunately they don't get much training or very little training in occupational health, and they just don't understand the relationship between work and our health. Being a bit tight
and it's a good thing you mentioned it before I started speaking. The hardest thing I have is to stick to 5 minutes. But first, let me say that I'm glad to be here. Marion's asked a couple of times for me to be here, and in my role, it's a dual role. As Marion introduced, I'm a workers' advocate, and I have been for 25 plus years. And I think that's the hardest role I play, because I've seen changes through the system. I've seen the change over time. And I'm now faced with what you're faced with, the current. And let me say I love doctors of PhD sorts, medical doctors, psychologists, psychiatrists, everyone, because you all play a very integral role. Because in my other role as chair of the board for OCAL, many of you who may not know what OCAL is, it's the occupational health clinics for Ontario workers. And we often lose sight of the fact that there's many facets to occupational health. And there's ways that we can provide different services to you in your advocacy, in your claims management. But I'm not here to promote or defend OCAL, because we are a free service. So we make no money from the promotion, but it's just by way of giving you that information. But by listening to the docs that have come up and the presenters, listening to the Quebec system, in my practice, I have Ottawa as one of my catchment areas, as well as Cornwall. So I have a lot of people who are cross-border from Quebec and Ontario. And I can say to you that there are many that love the Quebec system and many that hate the Quebec system. And I say that passionately, because those that have no problem in getting those quick opinions that are binding and get their claims allowed, love it. It's those that don't have that quick access and the quick decisions and the access to benefits and loss of earning benefits and the medical that's related, that's where they have the problem. So then when I cross the border over the river back into Ontario, I say we have a bigger problem because everything gets denied, and we have what I consider to be called the dueling doctors syndrome, right? Who has the biggest sword, who can fight the quickest, who can fight the fastest, and who can kill each other the quickest, because whoever slays the dragon first wins the argument. Well, that's not what this system is supposed to be. Meredith developed 5 principles. I think we've gotten so far away from them because of the bureaucracy that was mentioned in the presentations. But one of the things that struck me was when we talked about the paperwork that doctors have to do. I think that's one of the toughest areas, but it's an area where we have to educate the doctors. And not educate by telling them, but giving them the power, giving them the information that we know that we have, that they need to say, as long as it's within their ethical bounds, in the treatment of their patient. They then become the advocate. We can't get away from the fact that we're all advocates. I advocate for my workers. Doctors will advocate for their patients. But we can't say advocacy-type statements when replying back to the WSIB, because then they'll take our advocacy statements over our evidence-based statements. So we have to give the doctors the fuel in the fire. Oh God, here comes the 1 minute already. Oh, it's 1 minute left. So we also have to remember though too that the WSIB does have a document that we've been using lately that's been working, and that's the recognizing the time to heal. So look on the website, use it, because it's getting us through the door for some of those ambiguous areas of when the doctors say, look, listen to me, my patient needs that little bit of time before you speed them through the process and get them back to work. The other one is in the education of our doctors. I spend time with med students, and I spend time with doctors doing this, educating them. You talked about the forms, and I just wanted to get the phrase that you used. You become behavioral by the shape of the boxes. So just because you're faced with a tiny little 1 inch by 1 inch box doesn't mean you have to fit your paragraph into that little box. Use a separate piece of paper. And don't order tests that don't need to be ordered, because that becomes evidence later. So don't get victimized by the system just because of the request that's being placed on you by physicians to say, please provide. Because that one piece of evidence could weigh against the whole person. And the last couple of comments are, giving you the power. Maybe you need to have more of the information. You said you didn't know what the workers do. Well, then we have to get those physical demands analysis. We have to get those job descriptions. We have to give you the tools to give evidence-based opinions so that the board then can't turn around and defend against those and deny the benefits. And lastly, Marion asked us to answer these questions. So I'll answer those and then I'll stop. What struck me? Well, the issue of the gatekeeper role. I found it different, whether it's in the Quebec system or the Ontario system, but you are gatekeepers, but just be careful how you're opening and closing the gate, because we get squished in the middle. So ask us and we'll help you. The other one is what research? I think there's other areas of research that needs to happen, because there are all different kinds of illnesses and injuries out there. Noise, vibration, and mental injuries. We don't have enough information on that. Research, that's where we need to be going. I know OCAL, we're working on those areas, so anything that the Bancroft Institute can do to work with us on that would be great. And just so that you know, a group of advocates, it's in your leaflet here, that we've worked together, whether it's union or non-union. OCAL is now going to be the place in which it's called a repository, where all research documents, leading cases, decisions, we're going to house that information. So if you want to become part of that, where you will gain access as a worker advocate to those types of things, all you have to do is, perhaps, I don't know who's organizing, but if you have your email list and you indicate to us which email, if you want us to contact you, we'll put you on the list and you'll become part and parcel to that. And then how can we use today's research ideas? Well, that repository that I just talked about, it may then help change the way physicians are consulted and respected, whether you're in Ontario or in Quebec. So I think we have to work on all of those things, and I'll turn it over to Laura. Thank you.
Okay. Hi, everyone. So David just said that he loves doctors. I also love doctors in my work, but as a person, I'm actually terrified of them. So it's an interesting aside. I think the thing that struck me first of all was this idea that in Quebec, the doctors, not idea, I guess that's the way it is, in Quebec, the treating doctors' opinions are binding. And when I first heard that, I went, oh my gosh, that would be so wonderful to have in Ontario, because what we see is treating doctors just being ignored all the time. When I started to think a little bit more about it, though, I thought, well, maybe that also has some bad aspects too, like what happens when there's a doctor shortage and people don't have treating doctors and they have to go to walk-in clinics and they don't understand, and then you can't appeal. And also, I wonder about the strain that it puts on relationships between patients and their doctors if they don't see eye to eye, and then what happens to the patient in terms of treatment. So that, I think, is what struck me. It's an interesting question. Certainly, I think it would be wonderful if in Ontario the board actually listened to the treating doctors a little bit more, even if the decisions weren't binding. And related to that, as I was listening today, it struck me that there seems to be a bit of a culture brewing of mistrust of treating doctors at the board, in Ontario at least. And I say that because I think, as we know, doctors are often seen to be advocating for their patients when they shouldn't be. And if you listen to the language that you hear coming out of the board, we hear Elizabeth Whitmer saying, we're getting workers better treatment. We have these specialized programs. They're getting better medical care, and they're getting back to work. Well, what was happening to them before? Were they not getting good medical care? I don't think many of us think that's the case, right? Maybe in some isolated rural areas, people weren't getting care. But it's that language, right? And what does that say about doctors? And related to that is this practice that they now have of requesting clinical notes for time periods prior to the accident date. We see this especially with psychiatric claims. And here there's two elements. One, we know it's a fishing expedition. They're looking for things that they can use to blame other things other than the work accident for the development of the psychiatric condition. And the second thing is, again, there's a mistrust there, right? They don't trust that the doctor is actually being objective when they're providing a medical that says, yes, this accident led to the development of the depression. They don't trust that that's the case. They want to see the doctor's notes and make sure that they're telling the truth, essentially. And there's a problem there, because really the treating doctors are the ones who should be interpreting their own notes. They're the experts. They should be providing the opinions, and they should be listened to. And I won't even get into the hugely invasiveness of requesting those notes that I see as a problem, just because of lack of time. I was also very intrigued by this idea of the difference between the treating doctors and the independent medical assessors, because certainly we know that, we see that in the casework. But I think there's a bit of a kind of a middle area that we see developing in Ontario, and this is an area that I think would really benefit from some future research. And that's with the board actually sending people to these treatment clinics. So they are, these IMEs in a sense, except that they're also taking on a treatment role. But we know that they're not independent. They're paid by the board. They're part of these programs. And we know that they tell the board what they want to hear in the reports that they write. So I'd really like to see a little bit more work around that. I think it would be really helpful for us. And I think Willie's experience at Sunnybrook kind of highlighted some of that. The way that they write reports, even if they know the person can't work and can't go back to work, they just couch it in a language that allows the board to read in what they want to read in. And the final thing that I wanted to comment on was something that Katherine said early on about the U.S. situation and how your access to actually getting health care depends on your claim being accepted, I think there's actually a bit of a parallel with that going on in Ontario, which is funny, right, because we have the OHIP. But I think that's going on especially around psychological impairments and psych conditions. On the one hand, we have huge waiting lists for psychiatrists, so people aren't getting into the OHIP-funded care that way. And then we have the board where even when they're recognizing a psych condition, they'll only pay for like 10 treatment sessions with a psychologist, and then the person is cut off and, oh, well, I guess you're better, you know, or actually if you have any ongoing problems, it's because your dog died when you were 10 and it has nothing to do with your work injury. So they're limiting the treatment, so you're not getting the full diagnostic picture, and then you're not getting the entitlement to what often are permanent conditions.
We are, is it on? No? Okay. I guess this is for the machine, not for you. We are low on our scheduled time. However, we do have this room until 1 o'clock. So, as some people may have other things they have to get to, but Dr. Mamalak has very important things to say, and you probably have very important things to say, and I don't want to give either him or you short shrift. So just with that comment, people can just calm down, perhaps if they think that we're about to stop, but if you do need to go because of a time limitation, we understand.
I'd like to thank Marion Endicott for inviting me, and it's really very interesting for me to be here. I'd like to say that I've been working with injured workers for 45 years. I just wanted that other doctor to know. And I want to make some comments on how I think the system should be changed, because I don't see doctors playing all that big role in the system. I see the WSIB is mostly about money, not about treatment. We have OHIP, and doctors can access OHIP for treatment. OHIP, no matter what one says about OHIP, it is a wonderful system. If I had changes to make, if I had the power to make changes, the most important thing that I would do, the first thing that I would do, is say that no person who was working and earning a living is allowed to go into destitution if he's injured. There has to be a floor. That is the single most disastrous aspect of the entire system, that there is a very good chance that somewhere along the line, as they do these evaluations, you are either going to be in absolute destitution with virtually nothing coming in, or you are going to be in what I call run-of-the-mill destitution. That is, you are getting your welfare benefits. Welfare is a form of destitution. Poverty is the most serious disease in the society. It kills everything, and no matter what your injury is or no matter what your disease is, it is going to be compounded by the stress of poverty. So that is the number one thing that has to be changed, and I don't think it would be that expensive, because the present system of throwing the people on welfare and then watching the children go delinquent and putting the kids in the hospital and the mother is delinquent and the marriages break up, the cost to society is enormous. And we would be much better off if we prevented that from happening in the first place. How do the people get into destitution? Well, some of you have talked about it. The first thing is the independent examinations. I also believe these independent examinations are a waste of time. One thing that the doctor who does the independent examination is not accountable to the patient. That is a huge, huge problem. He can say whatever he likes. He can't really be, he doesn't have to be accountable to anybody for it. The term malingering has been around for nearly 200 years. It's a very, very damaging word. I do want to say that it's been finally recognized that malingering is such a damaging word that it's been taken out of the medical lexicon. It is no longer a medical term. A doctor who is using the word malingering is using it, he's telling the patient he's lying, but it's not a medical term. The medical community, the psychiatric community, that's where the term was listed as a diagnosis, has finally, after 200 years, taken it out of the lexicon. They realize that it's utterly damaging and of no value. I would like to see if you go for an independent examination, the doctor who does the independent examination has to give you the report. He can give it to the WSIB, but he has to tell you to your face that he thinks you're a liar. Without doing that, his report is of no value. That is the first thing that has to be changed. The second thing that has to be changed is videotapes. Videotaping people has to come to an end. It is some kind, more often than not, it is a way to discredit the person. You cannot tell from a videotape of somebody driving a car or shopping in a shopping center that that person is capable of holding down a job. Videotape evidence should not be allowed as such. It should be, if it's allowed, it should show overwhelming evidence that the guy is working and driving a steamroller on the trees. He's working and making a living. Most videotape evidence shows nothing. It shows the person walking in a shopping center. It shows him driving a car. It has no relation to his capacity to work. The third thing the WSIB has to change, or has to let us know, is their vocational rehabilitation programs. What is the success rate of these voc rehabilitation programs? The majority of people who hear that they are going to be enrolled in the WSIB rehabilitation program will say to you, that is not a rehabilitation program, that is the WSIB's ever-popular transfer to welfare program. Because you go through the program, the educational process is often dreadful, not well thought out. At the end they say, we'll continue to pay you, now go find a job. We give you 10 weeks to find a job. They don't find a job and they are cut off. That's the end of all benefits. I say the real gatekeeper in the system should not be the doctor trying to figure out what the nature of the injuries are, because the medical injuries themselves are extremely complex. Nobody has any idea what pain is. Nobody has any idea what depression is. Post-traumatic stress disorder, nobody has a clue really what it is and how to treat any of these things. That is the big problem. They are mysterious conditions that are untreated. The gatekeeper should be the employer. Does anybody want this guy? Does anybody want him? The employer should make the decision. If you are an injured worker and an employer hires you, then you got a job. But if you go to an employer and they say to you, the employer looks at you and says, I don't want this guy. And most of them don't want handicapped people. It's some kind of dreamland that the employer wants handicapped, injured people. Employers are under pressure to make money. Productivity, productivity, productivity. And these guys can't produce. That is the dilemma. The final decision about whether a person is employable or not should be made by a work trial. At least that should be a core step without a work trial, no decision should be made about whether a person is employable. Let us hear from the employer. Let us hear from rehabilitation workers who worked with the worker during the work trial.